is the nurse manager in the unit, and he and the nurses here have been really big supporters of all this effort to keep our patients safe. Patient safety and quality became a real passion of mine relatively late in my career. I was in Pittsburgh at Allegheny General Hospital as the chair of medicine, and I encountered a young woman who had leukemia. She was the mother of a 2-year-old child, a single parent, and she developed a bloodstream infection from a catheter she had in place. And what I learned in getting to know her was that kept her in the hospital for 17 more days, away from that child. And unfortunately, 7 days later, she died of the consequences of that infection. So I forever will remember the face of that woman and her little baby, and the potential opportunity we had to cure her, and unfortunately, inadvertently, we harmed her. And that memory lasts with me this day and has been the real reason why I've become such a passionate and interested party in safety. Be Safe is a platform. It's an approach that we use to try and create a common language and a shared discipline problem-solving approach to anything that goes wrong with a patient that causes harm. So it's simple. Every morning on my iPhone, I get a message. It says, yesterday in the hospital, there may have been an infection, and we gather at 10 o'clock, the entire leadership team, and we, including me, go to that place and that patient to see what might have happened to cause an infection, and we commit to eradicating it that day. And as a result, because we take this common language and this same platform that we've all agreed to, we've been really able to substantially reduce all of the infections at UVA. So in the month of August, we went for the first time in a long time with no infections in the entire organization. And this is a product of everybody sharing this purpose and using a common language. So there is an early investment, but the returns are astonishing. You know, the average bloodstream infection costs about somewhere between $25,000 and $40,000 more, so that every time you prevent one, you create freed up resources that can be used to do things that patients really want us to do, like providing new therapies and new technologies that get them home faster. Healthcare providers should be paid for providing a value, much like you pay a car dealer for the value of your car. Historically, that's not necessarily the way the payment system has worked. So as providers try to pivot to these new payment methodologies, it requires us to look at the way we deliver care and to ask the question, is everything we do adding value to that human being? And quite honestly, historically, there's a lot of what we do that adds no value. If we can eliminate waste in the form of harm or overtreatment or defects in care transitions like the readmissions we were talking about, suddenly we free up those resources to be able to cover the uninsured, or more importantly perhaps, or equally importantly, to take care of the baby boomers that are about to enter Medicare. How are we going to honor that commitment? We simply can't ask for more. We've got to figure out how to take those resources and make them useful. So we think this is a positive way to embrace reform. Not about cutting, it's about improving. The fastest adopters are our nurses, but among our most interested adopters are our medical students. We can't keep up with the requests we have from medical students to participate with our unit-based clinical leadership teams. You know, not everybody has to run an organization to be impactful, and what we're trying to teach these students is where you stand is your opportunity to make the kind of improvements and adjustments that will make healthcare for patients better. I would like UVA to, together with all the provider community in the Commonwealth, be able to stand up and rightfully take our place as the safest state to receive care.